So, a lot of my patients come and see me. Either they have symptomatic heart failure or they have an echocardiogram or something that shows that they have a reduced ejection fraction, and they come for a consultation, either because they're worried or because their physician wants an expert opinion. And I think it's important to frame where the patient lies on the trajectory of the disease. And usually I frame it in terms of stages. So if a patient comes to me who's asymptomatic, I can tell them that they're stage B. And usually when I frame it that way, that the symptoms are probably the most important prognostic factor, I think it's reassuring for patients to understand that where they lie. And if they come to me in stage C, I say, listen, you have stage C heart failure, but that doesn't mean you necessarily will progress. There are a lot of therapies we have to help you prevent progression and to stabilize your symptoms and to ensure that the heart failure doesn't get worse. I can't promise anything, but we also, it's our job to make sure that the patient understands the potential, and I always tell patients, hope for the best and plan for the worst.
So I'm going to take a little bit of a different approach to answering that question. One of the central things that we know about heart failure is that progression of heart failure is not linear. And this is one of the most difficult things for physicians to explain and for patients to understand. Um, you know, other conditions and diseases may be more linear. People get sick and they either improve or they don't improve and it's over. With heart failure, it's quite different. There are points in the disease where the risk of bad outcomes accelerates, and there's points in the disease where the risks of bad outcomes decelerates. And I think that teaching patients about that aspect of the disease progression is very important. So, for example, the concept that a hospitalization for acutely decompensated heart failure is just kind of a reset, I think that needs to be dispelled. It's not a reset. In fact, when somebody gets hospitalized for heart failure, even after we stabilize them, and we're quite good at stabilizing them, after that, the risk of bad outcomes actually accelerates. So even when heart failure feels quiet, it's actually not quiet. It's a phase of very high risk after hospitalization for heart failure. So I think that is a teaching moment. Now, when we see people in clinic and we initiate new medications, or when we increase the dose of medications, when we optimize GDMT, guideline-directed medical therapy, that's actually a point that's important. It's a teaching point because risk now is decelerating. So I think that is something important to keep in mind, just teaching patients about the trajectory and non-linearity of heart failure.
So, the question asks, why are so few of these therapies being prescribed? And I would rebut by saying that it's not necessarily that more therapies are more. Sometimes less is more, but sometimes, more importantly, selecting the appropriate therapies, the right therapies for the patient, are the most important things. And choosing therapies that are, number one, evidence-based, and number two, change the trajectory of the disease. So, we have the four pillars of heart failure: beta blocker, ACE/ARB or ARNI compound, MRAs, and SGLT2s. And, it's important for the patient to understand that all of those therapies work in concert to change the course of the disease. And, sometimes you have patients coming to you on multiple medications, and it's your job sometimes to deprescribe those medications. Now, having said that, of the patients that qualify for all four pillars of GDMT, probably only a fourth of them are on all four globally in the United States right now. So that's an issue. That's something that needs to be addressed in terms of the medical community at large.
I agree with Dr. Kadosh. I think that actually clinicians trust the evidence, and clinicians know that medications and other treatments are available and that they work. So underuse of medications is not due to disbelief in the benefits of the medications. I think that underuse is just due to an implementation gap. So, we know from the literature and from our practice that patients with heart failure on average are on 10 to 12 medications. Um, Implementing and making changes is very complicated in the real world. It takes time. There are not infrequently clinical concerns like patients have low blood pressure or they develop worsening renal function. There's fragmentation of care between specialists. These medications can be costly. Sometimes they require prior authorization. There's clinical inertia. And for all these reasons, there's an implementation gap that's slowing down our ability to get people on the right therapies. So I think that those are barriers to why available and proven medications are not being prescribed. It's that implementation gap.
And we have very strong evidence to show that you can start patients on these therapies. You can titrate them to target doses quite quickly, and that it's safe to do. And so people who live in this space, physicians who live in this heart failure space, tend to be much more bold about starting medications, titrating early. But I think that comes with experience, it comes with exposure. But also it allows an opportunity to create implementation in a way that maybe hasn't been done before. Maybe Eiran, you could speak to that. Using tools like the EHR, protocolized care, expanding the team.
Yeah, I think clinicians need an implementation playbook, and it needs to be protocolized in the same way that other treatments and other diseases like ST elevation myocardial infarction. I mean, these are protocol-driven therapies, and nothing is missed. And I think we need to do a better job in heart failure in creating a playbook and then implementing it. And some of those playbook steps include identifying people who are admitted for decompensated heart failure and then starting medications early and aggressively before discharge. Keeping in mind that the guidelines recommend these 4 pillars that Dr. Kadosh was referring to, and not shying away from using these medications. Having a plan to up-titrating medications every 2 to 4 weeks. And then we need to offload friction. We need to collaborate with pharmacists, on pharmacy-driven protocols, for example. We need to have prior authorization templates, order sets, nursing check-ins. So this is really a multiplayer sport. This is not just one clinician, doctor, nurse practitioner struggling alone. It has to be in context of a team, and that's what's going to reverse the trend.